Hi, and welcome to this presentation of Having a Good Death, which looks at the debate over the right to die in the U.S. My name is Cindy Rowe, and I'm an MSW student at Marywood University, and I'll be taking you through this presentation. Just a couple of tips before we get started. Be sure you're viewing this in the slideshow setting for optimum viewing, and so you can hear the voiceover. And also, I've included some source references within the slides to help you, in case you wanted to delve further into any of the points being discussed. That way, you'll be able to more easily see which sources were being referenced on any given topic. So this presentation will start with an overview of what palliative and hospice care are, before looking at aspects of serious illness that influence patients' quality of life and their wishes to hasten their death. We will then discuss the religious, cultural, and ethical considerations of physician-assisted death, which is sometimes called medical aid in dying, voluntarily stopping of eating and drinking, or VSED, and palliative sedation, and an overview of each. And then we'll look at the implications all this has for social work practice, then close with some participatory questions. So what is palliative care? Palliative care is a team approach to care that focuses on improving the quality of life for patients and families who've been affected by some type of life-threatening illness. Palliative care is appropriate for patients of any age and may be used during any point in the illness. Patients may receive palliative care concurrently with treatment aimed at curing or slowing the progression of their disease and at managing their pain and discomfort. I want to stress that last point here. Palliative care is not simply another fancy name for pain management. It's a holistic, total person approach to care. According to data from the most recent report on palliative care by the Center to Advance Palliative Care, some 12 million adults and 400,000 children are living with a life-threatening illness in the U.S. These patients are characterized not only by the presence of one or more serious medical illnesses, but also by their functional dependency on other caregivers to meet their basic needs, like feeding, toileting, bathing, and dressing. Notably, 37% of them report having used up their savings to pay for their health care, despite having medical insurance coverage. And as a result, approximately 23% of those patients reported being unable to pay for such basic necessities as food, heat, or housing. Additionally, more than a third expressed concerns about the strains and burdens of their care on their caregivers, who are often family members. However, contrary to common belief, though, only about 11% of them are considered to be in the last 12 months of life. A major arguing point against both voluntarily stopping eating and drinking and a physician-assisted death is the fact that barriers to accessibility of adequate palliative care exist. While great strides have been made in the last 10 years or so on the number of facilities that now provide palliative care, studies still have shown that smaller facilities are less likely to offer this type of care. And so typically, where are those smaller hospitals and facilities? Well, gee, not surprisingly, they're in rural areas. And this can force patients who live in rural areas to either travel to large cities for their treatment, such as New York City, or forego that kind of treatment altogether. So a primary argument against any form of patient suicide that we're looking at in this presentation is that the role of the palliative care team is to fully assess and address the various aspects of the illness that are troublesome to the patients. And until all patients everywhere can have full access to the full range of care and supports that they need, it's unethical to support any means that would hasten the death of the patient. Again, I want to stress the distinction between palliative care and palliative sedation. Palliative sedation refers to the use of medications to manage pain and suffering from serious health conditions in the end stages of life. And this, again, is just one aspect of the overall umbrella of palliative care. In a patient's final days, their discomfort might be so great that they may wish to be continually sedated to the point where they're unconscious. As we'll see a little later, palliative sedation is widely used when a patient has elected to forego eating and drinking. But again, we'll get to that in a minute. Because the nature of the pain meds is such that tolerance to them can easily occur, as we know with opiates, the levels of medication are often increased over time in order to maintain the patient's level of comfort. And those increasing levels of titration can impair the patient's heart rate and their breathing. And this in turn can hasten their death. So palliative sedation is sometimes chosen as a method to bring about death for people who are in the end stages of terminal illness. However, a major argument against this type of treatment in end-of-life care that's been noted in the literature is that it does not always fully alleviate all physical pain 100% of the time. So from the perspective of those who are in favor of physician-assisted death, they negatively view palliative sedation because they consider it to be extending a person's suffering. So what then is hospice? Hospice is a model of care that compassionately focuses on quality of life during the end stages of illness. Patients enter hospice when their life expectancy is 6 months or less, and at that point they've opted to forego any kind of treatment aimed at treating or curing their illness. Thus, hospice care provides them to have what many would call a good death by focusing on enhancing the patient's quality of life during their remaining time. Thus, key principles of hospice care involve letting the natural progression of dying proceed without actions that either postpone or hasten it. This helps us understand why the hospice community generally promotes high-quality end-of-life care and doesn't support the idea of physicians providing aid to the dying. However, because they also firmly believe and value personal dignity and the rights of patients to make their own decisions, the hospice community overall is accepting and supportive of patients who do choose to voluntarily stop all eating and drinking as a way to hasten their death. And lastly, while there is a distinction between palliative and hospice care, the two terms overall are used interchangeably most of the time. In looking at the comparison of these top causes of death in the U.S. and the number of patients who were receiving hospice care at the end of life, we see that nearly 540,000 people who died from heart disease in 2017, over 194,000, or approximately 36% of them, were receiving hospice care for an average of 82 days prior to their death. Similarly, 67% of those who passed from cancer, 91% from respiratory issues, 84% of stroke victims, 66% of them with dementia, and 58% of those who passed from kidney disease were cared for through hospice. Notably also is the average length of hospice care these patients had. Not surprisingly, those with dementia had the longest term of care in hospice, for an average of 110 days before they passed away. Overall, hospices served 1.49 million patients in 2017, 1.1 million of them who passed away during that time from their illness. And this indicates the scope of the role that hospice plays in end-of-life care. So in order to understand why the debate on a person's right to die is so controversial, we need to first understand the point of view of patients with terminal illness. There's a pretty robust body of research on the topic of the reasons patients cite for wanting to bring about their death. First and foremost, most patients in these studies indicated that they were ready to die and were accepting of the fact that their lives were coming to an end. Also, patients often want to end their suffering and pain, as well as the distress their loved ones experience from witnessing the patient's pain and discomfort. Emotional, spiritual, and existential distress, such as viewing their current situation as hopeless or pointless, or that they're a burden to their family and loved ones, are also major reasons that patients at the end of life stated as motivating their wish to hasten their death. Also, many patients indicated that being able to maintain some level of control over how and when they die was also a strong motivator in their wishes. It's important also to note that the literature was inconclusive about depression being a factor in patients who had expressed a desire to die. So while compassionate and supportive hospice care can help ease these concerns for many patients, it's important to always remember that if they express these wishes to die, it does not automatically mean that the patient is depressed, but rather that these expressions are a normal response, and that patients who do end up choosing any method for bringing about their death, that's a highly personal and deliberate decision that they're making. They oftentimes make it by speaking openly and honestly with their loved ones. Because terminal illness, impending death, and the prospect of taking steps to hasten one's death can trigger spiritual conflict in patients and their families, pastoral care is an integral part of palliative and hospice care. Thus, a large body of knowledge exists on the spiritual teachings of many different religions and how they inform ethical and moral decision-making to the end-of-life issues. A study by Mason, Kim, Martin, and Gabor surveyed clergy from Jewish, Protestant, and Catholic faiths on how they balance their moral beliefs of suicide with supporting those at the end stages of life who are considering hastening their death. Whereas a different study by Bake, Williams, and Brocart interviewed women of Judaism faiths, the ultra-Orthodox, Orthodox, and Reformist faiths, on their beliefs of whether it's permissible for a terminally ill person to do something that would bring about their death. Both of these studies found that among those in the Jewish faith, those among the stricter denominations drew on the sacred texts and teachings of Judaism to guide their decision-making, and that since they believed that life itself is a gift from God, only God has the authority to determine when it starts and ends. Whereas two other studies, again by Mason, Kim, Martin, and Gober, and Verbakel and Jaspers, they also noted that the sanctity of life and adherence to biblical teachings were equally important to Catholics. Protestants and those in the Reformist Jewish sect reported holding a more relaxed view on the right of a person to determine when they die, because they see God's role as giving people their start in life and the gifts of free will and rational thought to use as tools to direct the course of their life. Free will, so for them, means that a terminally ill person has the right and ability to decide for themselves the final direction of their life and their death. Importantly, the clergy in all these studies also spoke of the importance of supporting patients in their decisions, regardless of whether those decisions ran counter to the clergy's own moral or religious beliefs. And one clergy person, for example, was quoted as saying, "They're coming to me for pastoral care, not religious judgment or to hear religious dogma." While another said that the question to keep in mind isn't about whether the patient's choice is right or wrong, but it's about how can I walk with them. And this I thought was very poignant because it speaks to the social work concept of meeting the client where they are. I also found interesting pieces of literature that discuss how, these concepts of voluntary euthanasia, any of these forms of hastening your death, how that is supported in other cultures. The first article was on the views of death in Confucianism, which stresses that the two major values of Ren, which means benevolence, and Yi, which means justice, they're believed to represent the highest form of good. So much so that they supersede the value of life itself. And so just as life isn't the highest form of good in Confucianism, death and dying also do not represent the highest level of evil. So morally speaking, from the Confucianist perspective, sacrificing one's life for the principles of Ren and Yi are viewed as supremely honorable, while failing to do so, on the other hand, is seen as worse than death itself. Also, living a quality life means living life honorably and taking actions to ensure that one's dignity and the dignity of one's family is protected. Thus, Confucianism stresses that since living without dignity is a fate worse than death, it would be an honorable action for a terminally ill person to take some sort of steps to end their life in order to preserve their own and their family's dignity. This aspect of personal and family dignity also aligns with what was discussed in a study of Japanese nurses by Konish and Davis. And they noted that in the Japanese culture, patients with terminal illnesses tended to feel that they had a moral duty to die, particularly those whose care is a financial or practical burden on their family. So also within the Japanese culture, they view these forms of voluntary euthanasia in a positive light. A bulk of the literature reviewed for this presentation addressed the ethical issues regarding any type of euthanasia. Those in favor of voluntarily hastening one's death stand firm on the right to autonomy and self-direction of those in the end stages of life. As stated in the Ethical Principles and Ethical Standard 1.02 of the NASW Code of Ethics, social workers respect and promote the rights of clients to self-determination and assist clients in their efforts to identify and clarify their goals. Also, the ethical principle of social justice calls for social workers to pursue social change on behalf of vulnerable persons. Furthermore, as noted in Gweither and colleagues, social workers have a multidimensional role as clinicians, educators, advocates, policy analysts, and such, meaning that as social workers, we are in a unique position to provide support to the dying in a multitude of ways. Autonomy is also reflected in the Patient's Bill of Rights, which was created in 1973 by the American Hospital Association and has since been adopted as regular standard of practice in medicine. This expressly states that patients have the right to give informed consent for any and all aspects of their care, as well as the right to refuse medical treatment. So proponents of voluntarily stopping eating and drinking in particular, they argue that a patient has the right at any time to refuse eating and drinking and any other forms of feeding and hydration. In fact, patients can also expressly state such refusals in their advanced care directives. And as noted in Lachman's article, patients should be informed of all legal options to ease their suffering. Also, the International Association for Hospice and Palliative Care strongly support the position that patients' wishes regarding withholding or withdrawing treatments must be respected. One main argument against legalization of any type of physician-assisted death centers on the fact that palliative care is still not fully available to all patients. As we saw earlier, the number of facilities offering palliative care is still lacking in certain areas, particularly in the rural, underpopulated areas. So those holding this position argue that allowing patients to prematurely end their life without being able to even offer them services or resources such as palliative care, it does them a disservice because the patients don't even have the option to choose palliative care in the first place. Also, the literature stresses that assessing the underlying causes of distress, again, is really necessary. As stated previously, providing adequate care means addressing all the needs of these patients. And as stated in Gill's article, our efforts should be focused on raising the levels of skill among the healthcare team to relieve suffering, not getting rid of the problem by getting rid of the patient. On the other side of the argument, though, the separate articles by Gill and Schwartz also cite evidence from other studies that found that easing physical pain by medication isn't always successful for every patient all the time. Additional research found that other causes of discomfort, like shortness of breath, nausea, weak bones, and oozing wounds, they were forms of severe distress that pain medication just couldn't help. As we saw earlier, ending the suffering associated with pain, that was cited by patients as a primary reason for considering any measure to hasten their death. Also countering the improving palliative care argument was evidence cited in Gill's article, that found anywhere between 12 and 20% of terminally ill patients had expressed the desire to hasten their death, regardless of the fact that they were receiving good quality palliative care. The literature also discusses how the legalization of physician-aided death can open the door for abuse. They fear that legalizing physician-assisted death, that it would in turn give other entities power to make decisions about living and dying, like insurance companies, and that once that happens, decisions would be based on the financial costs of care rather than on what is best for the patient. Voluntarily stopping eating and drinking, or VSED for short, is a legal option for people who don't fit the criteria for physician-assisted death in some way, because patients do have the right to refuse any and all forms of treatment. So VSED is an option that helps preserve the dying person's right to self-determination and autonomy. And as we saw earlier, this is a method for hastening one's death that's common within hospice settings. It's more supported by hospice. However, doctors and clinicians, they can opt out of offering this type of support if they object for any personal or religious reasons. For many patients who elect VSED, they also typically elect to have palliative sedation as a way to maintain their comfort and manage their pain throughout their end stages of life. Also important is the fact that it's reversible. So if any time the dying person changes their mind about their desire to die, they can start eating and drinking again. But a major drawback to this approach is the length of time that it can take someone to pass. Because once they begin, on average, it takes approximately 7 to 10 days for the person to pass once they start. Regarding the number of patients who choose voluntarily stopping of eating and drinking, a recent study that surveyed 1,100 primary care doctors on the issue found that 62% of them reported having treated at least one patient who chose VSED, while a separate study of hospice nurses found that over 100 of them reported caring for patients who elected to hasten their deaths in this way. Also, they found that the overwhelming majority of patients were over 80 years old, 76% of them had a severe disease, and 77% were dependent on others for their daily care. And that relates all back to what we saw a little earlier with regarding patients who received hospice and palliative care. Other research on VSED found that among hospice patients in Oregon who chose some form of voluntary euthanasia, twice as many elected VSED instead of physician-assisted death, and that they were more likely to have a disease that interfered with their ability to swallow, which is a key factor given that in order to utilize a doctor's help in hastening death, the Death with Dignity law requires that patients be able to self-administer the lethal medication by swallowing it. Currently, physician-assisted death is legal in 10 U.S. states and territories: California, Colorado, the District of Columbia, Hawaii, Montana, Maine, New Jersey, Oregon, Vermont, and Washington. Because Oregon was the first state to legalize it, the structure of their law became like the blueprint for this legislation that other states have followed. So the basic rules of these statutes are that any mentally competent, terminally ill person who is at least 18 years old and a resident of the state where this type of aid is available, and who has a life expectancy of 6 months or less, and who can ingest medication, may hasten their death by obtaining a self-administrable, doctor-prescribed legal medication. A patient who decides on this must first make an oral request to obtain the medication from their primary doctor. Then 2 doctors have to agree that the patient meets all the legal criteria to follow through with this. A 15-day waiting period then starts. During this time, the patient gives a written request for the medication to their doctor, along with a consulting MD form, and makes a second verbal request. The written request must be witnessed by 2 people, one of whom must be a non-relative, not entitled to any inheritance, and they can't be the patient's doctor or any employee of a healthcare facility that serves the patient. A new change to Oregon law this year now waives the waiting period for patients who aren't expected to live longer than the amount of time that this waiting period entails. So then the prescribing doctor has to wait 48 hours after the date of the written request before they submit the prescription to the pharmacy. Decisions on whether to pick up the medication, who can pick it up, and ingesting it are made only by the patient, who is free to change their mind at any time. Lastly, the law prohibits life insurance benefits from being denied and stipulates that the illness be listed as the cause of death on the person's death certificate. Importantly, the laws do not compel doctors or pharmacists to serve patients if they're uncomfortable doing so. And notably, insurance companies also don't necessarily cover the cost of this medication. In looking at the drawbacks of physician-assisted death, the first is that not every patient will be a candidate. As we said before, in the U.S., only people who live in a handful of states where it's legal can follow through with this form of hastening their death. Secondly, patients with certain types of conditions, such as dementia, multiple sclerosis, Parkinson's, and ALS, aren't eligible because of the nature of the progression of those illnesses, which inhibit their ability to give verbally informed consent within the last 6 months of their life. Plus, the death with dignity laws do not permit stipulating physician-assisted death in advance directives, unlike VSED. Another key factor that's important is that the fact that once the medication is ingested, the likelihood that death could be reversed is relatively small. In looking at the most recent data available on the number of patients who elected physician-assisted death, we see that a total of 3,549 patients requested the medication from their doctors, while 68% of them ingested it. The states with the highest number of patients who sought this type of assistance were from Oregon, followed by Washington and California. In general, most patients who choose physician-assisted death, they were college-educated Caucasians who were between the age of 69 and 89 years old and had some type of terminal cancer. Notably, as seen in this chart, patients were pretty evenly split according to gender, with 50% of males and 49.3% of females choosing this option. So in looking at the implications for social work practice, it's first important for social workers to maintain the holistic view of the patient and their loved ones. And as part of an interdisciplinary care team, part of the role of the social worker involves ensuring that other members on the team understand the interplay between the physical, emotional, spiritual, and financial distresses patients and their families might be experiencing, as well as advocating on the patient's and family's behalf to help ensure that all their needs are being met. Thus, the responsibility for fully assessing their needs and creating the care plan to address all those needs, that falls on the social worker. Also, in order to be able to work in this specific type of setting, social workers have to educate themselves on end-of-life issues. So in order to address that, NASW developed its own certification specifically for hospice and palliative care, along with a set of specific competencies for social workers in this concentration. Social workers in this concentration also need to educate themselves on things such as the symptoms of different types of illnesses, the treatment options, and the prognoses of these different types of diseases, the impacts of the illness on the patient and family, and how those impacts can drive a patient's desire to hasten their death, as well as educating themselves on the death process itself. And because social workers have the ethical responsibility to support people's right to self-determination, social workers have an obligation to provide patients with information pertaining to VSED and physician-assisted death if it's legal and if the patient requests it. Social workers also play a key role in providing family members with grief and bereavement support after their loved one's death. So they also need to be knowledgeable about the different models and therapeutic approaches to this type of care. And lastly, social workers also need to have a keen awareness of their own thoughts and feelings about their work and their patients, and take steps to process the countertransference that occurs, and to be mindful of how their own personal beliefs about physician-assisted death and VSED, how that might interfere with their ability to remain neutral in their dealings with patients who request that information. In considering what you've seen in this presentation, what parts of the NASW Code of Ethics support a person's right to choose how and when they die? And conversely, what parts of the code could be used to support the argument against a person's right to die? And secondly, if you were a social worker whose terminally ill patient expressed a strong desire to end their life, what would influence how you would respond to them? So this concludes this presentation. And for further reading on this topic, you can check out these two articles or any of the other sources that I've included on the reference pages that follow. Additionally, I've included here a link to a video that tells the story about Brittany Maynard, who is a young lady who chose to use physician-assisted death in her end stages of life. Also, if you're interested in learning more about death and grief in the context of social work, visit my YouTube channel, which I've listed here, where you can see presentations on a wide range of other topics. Thanks so much for watching.